very warm welcome to all the clinicians and optometrists who have joined the course. This is chapter 2 of myopia documentation guidelines and best practices. I think this is a very apt time because tomorrow, from day after tomorrow, we are having the Myopia Awareness Week, which starts on 19th May. We have been celebrating, or rather, we have been uh, giving more and more awareness on 19th May, which we celebrate as Anti-Myopia Day, because my son, who is a myope, uh, was the first patient for us whom we started treating with atropine, and he was born on 19th May, and we do keep 19th May as Anti-Myopia Day since last 8 to 10 years. And this particular week, Brand Vision Institute have issued a very good poster to seriously tell everybody about myopia and what are the risks of serious sight-threatening complications that can happen with myopia and myopic progression. You can see I've kept that as the main picture in this particular slide, just to make sure that everybody understands that myopia is really a big problem, and especially the progression of myopia. They have very nicely shown how myopia can lead to serious other eye diseases like myopic maculopathy, and the chances of this myopic maculopathy goes on increasing as the myopia progresses. So it is very important for us to understand and make everybody, all the parents and all the clinicians also, educate and make them understand that myopia progression is serious, and there is a lot of work which is going on across the globe to stop or curb this particular progression, mainly because with each diopter, that increase occurs, the chances of myopic maculopathy, retinal detachment, posterior subcapsular cataract, glaucoma go multifold. It is not just, you can see that myopic maculopathy, the chances of myopic maculopathy goes from 2.2 times to 9.7 times to 40.6 times and higher, and almost to 126.8 times higher if your uh, dioptric power is more than 8 diopters. So it is pretty serious, and with increasing prevalence of myopia, there is a good chance that there will be a lot of progressors of myopia, and once they progress beyond 4 diopters to high myopia to 6 diopters, it is truly serious, because all the problems of myopic maculopathy, detachment, posterior subcapsular cataract, glaucoma increase multifold due to myopic progression. So this is where we have to start thinking about it more and more seriously. I think this is a wonderful initiative by Brian Holden Vision Institute, who were also the pioneers in telling the world that this is the true picture and this is going to worsen by 2050. I think the whole act of myopia and myopia progression started with their remarkable, or I would say, path-breaking article where they tried to extrapolate the data which was already available. Unfortunately, in that particular data, there was not much of Indian data, but I think Pawan Varkicharla and their group did publish the Indian temporal trends, and we talked about it in our last the chapter 1 talk on myopia and what are the risk factors of myopic progression. So in this particular video, we will be mainly talking about what are the how to document, what is to be documented, what is important on the first visit and on the second visit, how frequently we should have visits, what are the best practices. We have taken guidelines from Brian Holton Vision Institute. We have touched upon the guidelines from Impact, which was published in IGO by LBP. I was part of the group where we published how to, how in Indian eyes, what is the difference and how we can do that. We have also taken loosely, we have taken guidelines from the All India Ophthalmological Society publications. So we would see all that, what is new, what has come up now, what are the newer machines which are there, that we will see. So the first step is obviously to find out whether the patient is myopic or not. Number one, that's very, very important. And the most important point that is to be touched upon next is what is the risk factor. You have to go into a detailed history of what is the age at presentation. Younger the age, more are the chances of progression, more are the chances that this particular patient will be a non-responder to bulk of the treatments. Second most important point, and we have already touched upon these things, and we will be talking about it more and more frequently, about parental myopia, sibling myopia, and the role of parental and sibling myopia into pre-myopia as well as myopia and myopic progression. Ethnicity, we have seen that atropine does work really nice in Asian population and in Indian population also. We have our own Indian atom study. We have atom study published from Singapore, and we have wonderful data from LAMP 1 and LAMP 2 studies. So we have a lot of data which does suggest that atropine is doing very well, even in very low concentration, at least for Asian and Indian population. And the progression of myopia, prevalence of myopia is also on the rise for these particular target areas like Southeast Asia. Prematurity, yes. Now, prematurity is very, very important to know, because the path of myopia that occurs in prematurity is basically the crowded anterior segment and not really axial myopia. However, having said that, there are set of patients who have this crowded anterior segment, corneal curvature is on the higher side, the lens diaphragm is slightly on the anterior side, and there is actually a relatively the anterior segment is disproportionate to the posterior segment. So axial length is not much in these patients, but yes, over a period of time now we have found that these patients are not really immune to myopia progression, just like school going children. But prematurity myopia is different. However, if you see a patient who is progressing axially and is a premature kid, you can always think of starting some appropriate anti-myopia progression therapy. You have to go into details of what exactly the kid is doing. There is a lack of outdoor time, how much time he's sitting outdoor, what is the excessive near base time, avid readers, sitting more on mobiles, doing a lot of work on mobile, the homeworks are on mobile or on laptops, and they are putting in a lot of time for near work, for computer based games, or they are doing a lot of PS station. And what is the history of progression, how quickly the kid is progressing, whether the kid is progressing a half adapter. So this also, patient would be more and more happy to share how quickly he is progressing, because sometimes, or rather when you will start developing your myopia practice, patients will come to you directly and they will let you know that they have been sent because their power is progressing faster and there is no answer to anybody else, and so they have come to you for faster progression and not just progression. So normally a progression, how much is the progression, we will see in coming slides about what is dubbed as progression. So step two obviously is to find out the visual acuity, which is the basis of ophthalmological examination. Cycloplegic refraction is the cornerstone. We cannot, you cannot overemphasize, especially in myopes, that cycloplegic refraction is a must, because myopes or these kids who are younger than 18 years would be doing lot of accommodation, and it is very easy to miss an accommodative spasm or a borderline, borderline hyperope or a emetrope, and erroneously you would see a lot of patients who are actually using myopic glasses and they are not actually myopes. So a lot of patients do come to us initially, and we do not start them in anti-myopia therapy or anti-myopia progression therapy, because when they have come to our clinic we have actually reduced their power, and we often see that these patients are wearing overcorrections or they are into overcorrection. So giving overcorrection is another risk factor, because that would be inducing, it would be inducing over accommodation and over stress on the eyes. Post-pediatric tests in patients where you are doubtful, in patients where you feel that there's a chance that patient may accept 0.25 less than what you have given, it is always better to either do a duochrome when you are doing post-pediatric test if the patient is cooperative, or at least do a post-pediatric test and ask the patient whether he can see the letters clearly, and it is there is no minification of the letters at distance visual acuity. So glasses are given uh, for most of the part. Whatever is the power, you have to give full correction. And there is, I have not included those articles, but there is lot of evidence which now easily and clearly suggests that under correction doesn't really work in myopic patients. And then we come to certain baseline investigations which are very, very important, like baseline keratometry, axial length, fundus evaluation, and pachymetry. And we will see how these are particularly useful, because these are the parameters which will actually tell you that the growth is axial or not. So keratometry, axial length, and axial length upon corneal radius ratio is now supposed to be the baseline, apart from also doing pupil size, because if you are going to start atropine, you should have a baseline. You should also do some more tests like accommodative lag. We will see upon it on the coming slides. So this is a basic basic guideline of what we do in our clinic. So typically this is a sheet which we make in our clinic: the name of the patient, medical record number, baseline data, K1, K2, and K1, K2 of the left eye, and then you take an average of that, and then you convert it to the radius, and then you do the axial length upon corneal radius ratio. So this was a patient who came to us in August 2019 for the first time, and this was the axial length upon corneal radius ratio. So you have to convert the dioptric power into radius, and then take the take the axial length and divide it with the corneal. So what they have found is that it is axial length upon CR ratio which is more sensitive compared to only axial length data, because the variance, which the correlation between axial length and spherical equivalent, is more clearly shown by AL upon CR ratio, and anything beyond 3 is normally considered little bit of a risk factor that there will be progression. So we will see upon those articles also where they have talked upon axial length by CR radius. But this sheet I will be sharing, I will also be sharing the Excel sheet of how you can do it yourself. You can just change the name and start using it for your purpose. These are the dates on which patient came. I think that there's an error here, but otherwise these are the dates which the patient came, and this is how the axial length elongation is correlating, and this is where I think atropine or some myopia was atropine was started. Still the patient was progressing, and I think this patient was finally put on the combination therapy of glasses and atropine. The important point of making such a sheet is that it is very easy for you to tell the patient that this is what is going on, and they can see for themselves how the power and the axial length is increasing. Now there are certain devices now available which can do this work for you, but nevertheless you can always tell your optometrist to make a separate sheet for yourself for your reference. Now, these are the articles I was talking about. This was the upper article was published in 2024, and the lower one was just came by Sandra from Arvind Eye Hospital, Arvind Eye Hospital, Coimbatore. And so this is all basically what they have done is they have taken axial length, divided it by corneal curvature radius, and they found that in myopia, the association of AL upon CR ratio was much closer compared to just axial length with the spherical equivalent. Now you can see that this is another article. This came 3 years back, and you can see what they have done is they have divided in age. This is the spherical equivalent. This is the axial length. Now what they do basically is how do they find out the correlation is that they try to see how much correlation is between 23 and 1, 23 and 2.66, and how much is the correlation with this. And you can see that the prevalence of myopia is goes on increasing as you see that AL upon CR ratio goes on increasing. So now, at least at this point of time, there is a good body of evidence that we should also incorporate axial length upon CR ratio in our armamentarium, which we are already doing. Not that we do not have a keratometry, we were not knowing about keratometry and axial length, but we were not making it sensitive enough, because once you take axial length and divide it by CR ratio, this particular ratio becomes more sensitive and correlates more with the spherical equivalent rather than the axial length alone. So that was regarding axial length and CR ratio. And the algorithm by BHVI and IMI also I would share you on the WhatsApp group. Uh, the stepwise approach which they have suggested is very similar to what we have already discussed and what we will also be discovering. Very closely similar to impact guidelines, very similar to what we have been doing. Basically, it includes an initial consultation which we already discussed, and then assessment for risk for onset, what are the management strategies, and follow-up. So more importantly, this particular link will also take you to a myopia calculator. Now, Myopia calculator is a fantastic calculator, and it has been incorporated with Myopia Master by Oculus people, but it is available separately, free of cost, online. It has been upgraded, and now it has been divided into three parts. The first part is about how much would be the myopia progression. The second part, as you can see in this video, the second part is about what are the risk factors, and third is about pre-myopia. Just taken a video, just recorded the screen how you can do it. You can see you can select the ethnicity, you can select the age, gender, what is the refractive error with which the patient has presented. Now what you can see here is that, with atropine low dose, if you are giving, you have to select what particular treatment you want to start. And if you go to orthokeratology, it will immediately tell you that orthokeratology at this point of time, the efficacy is not available. So that is the only thing. Apart from that, whatever you select, it will tell you two things. The graph is interesting, and you can always print this graph for the patient to tell them in green what will happen with management, and in red what will happen without management, and what is the expected refractive error. You see, this is where it is interesting, that if you are giving a treatment with very high dose atropine, the expected refractive error would remain same at 0.56 diopters, and if nothing is done, the refractive error may climb up to minus 5.5 diopter. Now this is what it gradually shows. You can also change the initial refractive error. You can see with management, without management. So basically the parameters are pretty simple. The parameters are age, the parameter is initial presentation of refractive error, and the third parameter is what is the myopia management option. To tell the patient what are the combination therapies, what are the atropine therapies, what are the separate peripheral defocus lenses, what is combination therapy of OK, that is orthokeratology with atropine. So you can select these different things if you have time, and if you have a separate person for this, you can select these separate things and take a print and show it to the patient, customize it, tell the patient what will happen with management and what will happen without management if nothing is done. So this is a completely free software. You can see expected refractive error and what will happen if you use a peripheral defocus lens, what is the percentage of reduction. The second part is on the axial elongation. The first part is on the myopia progression. The second part is how much is the expected axial elongation over a period of time. So if this is the age, this is the refractive error, and if this is the corresponding axial length, what would be the final axial length as the time goes. This is also a very important tool when you try to tell the patient that what you are talking about, what is axial length, how much axial length can increase, what is the percentage, what is atropine doing with this, how much percentage reduction atropine is giving. And then third part is the risk of myopia. We saw the pre-myopia calculator in my last lecture, which was part 3 of the first chapter. This is another very close to very similar pre-myopia calculator, or You can say that what are the risk factor in pre-myopes. So here what they have done is they have gone into the hyperopic reserve of the patient and sibling myopia, parental myopia. So these are the two things which are important apart from age at presentation. So if you see, if you remove parental myopia, most important is that they are going mainly by refractive error. If you put too much of plus error, whether parents are myopes or not, the probability of child being myope is very less. So my point, which I'm trying to make here, is that the initial presentation refractive error is more important than anything else. I would like to add here is that we should also take axial length, and children who are pre-myopes should always be taken very seriously with regards to progression of myopia. If there is a presence of sibling myopia, even in absence of that, if you have children in whom you feel that this patient is losing out on his hyperopic reserve very quickly, the probability that this patient would become a myope and would further progress into myopia is pretty high. So that was regarding BHVI myopia calculator. A similar calculator, and I have not included that, but a similar calculator is there from LVP, which is available on their website. Yeah. So this is The impact guideline that I was talking about, this was published at IGO. So step one, as I said in my preceding slides, you have to identify the true axial myope. What do you want for that? You want a keratometry, you want an axial length, you want a cycloplegic refraction. We discussed it. What else you need? You need to do axial length upon CR ratio. I know it was not really important when this particular guidelines were published. It was not much known. Hyperopic reserve was also not talked much about. Parental myopia, yes, I think it is there in step two of this particular article where they talked about mapping the risk factors. So I think mapping the risk factors are the risk factors we have already taken into account. Apart from that, axial length CR ratio and hyperopic reserve, these two are equally important when we talk about mapping the risk factors of a myope. So the second step is to map the risk factors. We already talked about it, the detailed history part of it, whether the patient was premature, the age of presentation, which is very, very important, presence of myopic parents, and we have been repeatedly talking about the same things regarding age, myopic parents, less time outdoors, excessive near work, relative peripheral hyperopia. This has come up into discussion for the first time. So relative peripheral hyperopia, what it really means is that the peripheral part of the retina is in a form of a curvature, and thereby the rays of light are not truly focusing on the retina and are focusing behind it, which makes it a relative peripheral hyperopia. High lag of accommodation has been described as one of the risk factors, and esophoria for near has also been described as a risk factor. Now you have to pick a progressive myope, because that is what is the whole aim of this myopia progression control, is to pick up a progressive myope. The risk factors tell you that this particular patient can be a progressive myope, but you have to truly monitor progression and find out if there is a progression and whether that particular progression is secondary to axial length elongation. Only then there is a progressive myope who is progressing axially. So any increase on follow-up has to be noted, and you have to repeat the same investigations that we did for baseline and compare if there is a true axial length elongation over a period of 6 months and then over a period of year, and then we can say that this is a progressive myope. So we have to treat after 6 months once we have waited enough and there is a history and background that this particular patient is progressing gradually and it is an axial progression. So appropriate treatment